So good morning, good afternoon and good evening all. Bonjour et bienvenue. A very warm welcome on behalf of the MIT and Research Links events team. We are very much looking forward to supporting you with today's session, putting schistosomiasis precision mapping into practice. And I'm now delighted to hand over to Lee Hundley to welcome you to the session. Thank you.
Thank you, Debbie. Hello, everyone, and welcome once again to today's Research Links session ahead of our annual meeting of the Coalition for Operational Research on Neglected Tropical Diseases, or CORE-NTD, which will be taking place November 8th through the 10th this year. My name is Lee Hundley, and I am the technical lead with the NTD Support Center at the Task Force for Global Health. We're very pleased to present today's session, Putting Schistosomiasis Precision Mapping into Practice, and we are looking forward to some engaging presentations and discussion. With that, I would like to turn it over to one of today's moderators, Professor David Rawlinson, who is the director of the Global Schistosomiasis Alliance. Welcome, David.
Thank you, Lee, and hello, everybody, and a very warm welcome to our meeting. Thank you so much for joining what I'm sure will be an interesting and informative session, and update some of our CORE-NTD discussions from last year, and I know many of you participated in those. I think all of us who are involved in schistosomiasis control and elimination understand the very basic requirement to better capture the focality of the disease, to reach those that need treatment, and to ensure the best use of available drugs. Focality is dependent on the availability of fresh water, suitable snail hosts, and on human and animal water contact, and this can change over small geographical distances. Treatment decisions based entirely on limited mapping data from large administrative units, such as districts, we know can be misleading, and there is a recognized need to move to the sub-district level to better target preventive chemotherapy. Of course, to achieve precision mapping, appropriate sampling strategies and good diagnostics need to be in place. But sometimes what may seem to be an obvious and logical step may, however, be logistically difficult and challenging to achieve on the ground, especially with extremely limited resources, and even more so as we've seen over the past 18 months during the COVID-19 pandemic. During this meeting, we're going to be conducting a poll, and I'd now like to ask MIT just to display the poll so we can get started with that, the first three questions, if that's possible. If you could just answer those, there's the first one. I think the others will come up and submit them. We can then move on. But the underlying question really is, how do we better target treatments to ensure praziquantel is available for those in most need and is not wasted in areas where treatments may not be needed? And although we speak primarily of drug treatments, we should also factor in other interventions that may also be needed. So good progress is being made, and many countries have followed the advice and training offered by ESPEN and others relating to the mapping protocols, and many countries have moved implementation of their programs down from district to sub-district level. So I'd like now to just share the agenda, ask MIT to share the agenda. The first slide will be in English, but then it will be followed in French. The first session, we will have overviews on mapping and surveys, and this will be followed by in-depth country experiences from Kenya, Tanzania, Cameroon, and Rwanda, and then the Q&A session based on the questions that arise in the chat. And I would emphasize the need to put your questions into the Q&A sessions for the discussion, which will actually happen after the country experiences. We do really hope to get a clear understanding of the benefits of precision mapping protocol and development, of best practices for countries who may be looking to undertake these protocols in the near future, and some of the discussion that we hope will take place in the interactive breakout discussions, I'm sure will be of benefit for this. I don't know if we've shown the French version of the slide, that could follow. So I think we can also begin to start thinking now about our presentations and move forward to that. Just to re-emphasize, please put your questions in the chat. We are very fortunate to have Dr. Pauline Winsey, the Schisto and SDH Technical Officer for ESPN in the WHO Afro region. And Pauline has done so much to support control and elimination efforts. I'm sure we all appreciate her sterling work in this area. Today, she will be giving an update on the schistosomiasis sub-district level data optimization, analysis, validation, and implementation. So over to you, please, Pauline, for the first presentation.
Good morning, good afternoon. My name is Pauline Winsey, and I am the Technical Officer for Schistosomiasis at the WHO Regional Office for Africa. I'm glad to present an update on schistosomiasis sub-district level data optimization, analysis, validation, and implementation in the WHO Africa region. Current WHO guidelines require countries to implement schistosomiasis interventions at community levels. The current WHO Afro NTD mapping protocol as well requires mapping to be conducted at some district levels. However, due to resource constraints and other challenges in the past, data collected during mapping surveys has not been adequate for decision-making at the community level, and several countries have been making intervention decisions for regional or district levels, leading to inadequacy in the intervention strategies. Therefore, since 2018, we have provided technical support to endemic countries to collect schistosomiasis AP data and organized joint working sessions with NTD data experts to develop a sub-district analysis tool and training manual. We've organized learning sessions with countries in a couple of workshops in Brazzaville, as well as virtual workshops since 2020 to ensure alignment with NTD programs. The country-specific virtual workshops since 2020 are ongoing to support countries that are still reviewing their data for unadjusted medicine applications. The AP data and demographic data from the countries is subjected to a decision tree and a decision made for each sub-district based on availability of data or lack of data. Where data is lacking, the decision tree provides for a process of determining if intervention should be continued based on environmental suitability for transmission and a qualitative risk assessment at community level. This data is generated into a workbook from where it can be transferred into the joint application package and used to update the joint request for medicines for the specific year. The current version of this tool allows for automated data transfer between existing and new versions of the tool, automated filing of the joint application package that refers to the joint request for medicine for praziquantel, and the joint reporting form for AP data. From this tool, generation of 5 years treatment requirements for the projections, and use of qualitative environmental suitability determinations, as well as community health worker local knowledge at frontline health facilities. Automation of the schistosomiasis community level risk assessment questionnaire into the sub-district workshop is one of the recent updates. The risk assessment questionnaire is used at the frontline health facilities by health workers at this level to help validate disease transmission by indicating detection of disease at these levels, human-water contact activities, and presence of the relevant snail intermediate hosts. It also serves to educate health workers at the community levels about the disease and its transmission, including identification of snail intermediate hosts, and can fill decision-making gaps in communities where epidemiological data is lacking. So far, of the 37 countries that need to update their data analysis at sub-district levels, 11 finalized data analysis in 2020 and made medicine requests based on sub-district level data, while this number grew to 28 countries in 2021. We expect that the analytics by individual countries will be availed on the ESPEN portal for countries that submit their validated workbooks and updated joint request for medicines. And this includes a proposed dashboard for easy interaction with the data. The impact at regional level based on countries that submitted updated joint request for medicines in 2020, which represents only 24% of the total sub districts, is that we can address the gap of 18% school-age children that are missing treatments when interventions are implemented at district levels, and save on medicines that go to 19% of school-age children that are treated unnecessarily, and overall reduce the under-treatments and over-treatments, thus ensuring medicines only go to those that need them. In the few examples of countries selected here, you can see that the overall quantities of medicines needed by the country may not differ significantly because the medicines move from areas they are not needed to the specific transmission areas where they are needed. Overall, based on the learning process from this data analysis, engaging all implementation stakeholders at country levels, there has been a greater appreciation and awareness within the schistosomiasis community on the focal nature of schistosomiasis transmission, which has contributed to progress in sub-district mapping of the disease. There is a reduction in number of school-age children being treated unnecessarily in the medicine applications that we have received so far, and those not getting treatment when they need it, which are up to 18%. Overall, addressing about 37% of inadequately treated school-age children. We also expect that more medicine may be available for adults' treatments, and this discussion is being held with the medicine donor on a country case-by-case basis. The schistosomiasis sub-district data analysis tool can be used beyond the current schistosomiasis data gaps filling efforts, and these opportunities are being explored. More importantly, the mapping gap has been made visible at the sub-district level, where we have up to 76% of sub-districts that do not have data. And we urge countries to review this gap using the provided tool when considering their impact assessment planning. Thus, this sub-district data analysis tool is being used to help countries develop their precision mapping protocols, and the tool will be used to receive sub-district data from countries from the further mapping and impact surveys that will be conducted henceforth. And we are looking forward to the data from the ongoing such surveys. Thank you for your attention.
Thank you very much, Pauline. This really is great to see the progress made since 2018 and the evolution of the decision tree. I'm sure there'll be lots of questions and comments relating to that. Please do place them into the chat. We now move rapidly on to our next presentation, and it's a pleasure to introduce Dr. Fiona Fleming, Director of Monitoring, Evaluation and Operational Research at the Schistosomiasis Control Initiative Foundation. Fiona has been a leading light in the development of best approaches in this area and will give an overview now of the ongoing schistosomiasis oversampling study. Fiona, please.
Hello, I'm here to provide an overview on the schistosomiasis oversampling surveys. I wanted to start with a slide on partnership to emphasise that the schistosomiasis oversampling surveys have not been as a result of one person or one small group, but have been the evolution of several ideas by many individuals and teams working towards a common interest to have better data for decision making in schistosomiasis. This is a thank you to all those folks for supporting where we are now. However, let me start with some background for context. In late 2018, the WHO convened a technical working group on protocols for remapping and impact assessment. Use cases were developed, with use case 2 to determine targeted treatment strategy at sub-implementation unit chosen as a priority use case. 3 different survey designs were then developed, discussed, and deliberated. With the 3 survey designs, there remain questions around the age groups, sampling units, and sample sizes to use. And despite a keenness to test the 3 survey designs in multiple countries, the pause in programmatic surveys due to the COVID-19 pandemic provided the opportunity to think around the challenge a bit more through a series of informal technical meetings, which culminated in wider discussions during the Core NTD and GSA virtual pre-sessions in late 2020 and the setting up of the schistosomiasis oversampling surveys. The Schistosomiasis Oversampling Surveys is an operational research group funded through Core NTD by USAID and the Bill and Melinda Gates Foundation, with surveys led by the health ministries in Ghana, Cote d'Ivoire, Mali and Togo, with support from the Secretariat comprised of Katie Gass at the NTD Support Centre, Rachel Poulin at LSHTM, Penelope Vanatsu at Swiss TPH, myself and more recently by Stella Kefa from Kemri. And let me admit now that many of today's slides are acquired from that group, so many thanks to them. The rationale for the schistosomiasis oversampling surveys really comes down to why are sub-district assessments needed? District-wide mass drug administration is contributing to over and or under-treatment in endemic countries. There's a need to target preventive chemotherapy and resources only where it's needed. And by this more effective targeting, this may enable an increase in resources for adult populations. There's also a need to assess the reduction in the number of people requiring preventive chemotherapy, as well as determining whether elimination as a public health problem has been reached and WHO targets have been met. We need a programmatically feasible epidemiological assessment that can be used by health ministries to make decisions at a sub-district level on schistosomiasis interventions. Feasible in terms of a sample size, cost, sampling frame and expertise required. There are lots of potential survey designs out there. Today we'll hear in more detail several of the survey designs implemented to support more precise estimates for sub-district decision making. These figures are of precision mapping led by the health ministries in Uganda on the left and Tanzania on the right, with design support from the SCI Foundation to ensure precise sub-implementation unit decision making. The surveys were developed from the desire of the health ministries to reassess the distribution of schistosomiasis with respect to the ecological zones around Lake Victoria, determine changes in prevalence over time, and to reduce the number of treatments required annually. To ensure precision around the prevalence estimates at the Uganda parish zones and the Tanzania ward, the survey sampled 8 to 9 schools and 7 schools in those units respectively. That's a lot of schools. It's also expensive and inefficient to replicate across multiple regions and all endemic districts. So how can we effectively evaluate the performance of multiple surveys across multiple settings? We could field test, but it's very expensive to replicate multiple survey designs over multiple settings. And how do we interpret the results into intervention decisions? And how do we ultimately determine which is best? Or we could simulate. But what data underlay our simulations? And how reliable is our truth? Simulating using existing data to generate realistic prevalence surfaces of schistosomiasis distribution would be more affordable than multiple field surveys. And these surfaces could be used for trialling multiple alternative approaches and systematically compare the designs. But, and there's always a but, isn't there? But there are very few settings where we have sufficiently detailed epidemiological data that accurately describe the fine-scale distribution of schistosomiasis after multiple years of treatment. From this conundrum, the schistosomiasis oversampling surveys were born. Our approach is through 3 phases. Phase 1 is to collaborate with health ministries on planned programmatic surveys in 2021 and determine opportunities for schistosomiasis oversampling, and then subsequently develop country-specific protocols. Phase 2 is to collect comprehensive parasitological data through schistosomiasis oversampling surveys, the SOS, in multiple settings after several treatment rounds of age-targeted preventive chemotherapy. And phase 3 is to use these SOS data plus additional precision mapping survey data to generate truth surfaces, which can be used to evaluate the programmatic feasibility of alternative assessment survey protocols using simulations. We are currently in phase 2. The primary aim is to provide a detailed epidemiological understanding of the distribution of schistosoma mantsoni and hematobium in school-aged children after multiple rounds of preventive chemotherapy across multiple settings. And we're using a term for that of archetypes. Within this understanding, we'll be able to characterize spatial variation in infection prevalence in school-aged children within and between sub-implementation units, identify potential bias associated with sampling in schools versus sampling in communities, and to assess if these characteristics vary across archetypes, and identify important socio-demographic, environmental, and programmatic factors associated with variation in prevalence within IUs. The secondary aim is to describe schistosoma mantsoni and hematobium age infection profiles in school-aged children and adults after multiple rounds of preventive chemotherapy in a subset of the locations sampled under the primary aim. I will now provide a brief overview of the sampling plan for the primary aim. There will be 3 contiguous districts selected, which will be the survey area. Within these 3 contiguous districts, the primary sampling unit will be a village, a locality, or enumeration area, and 30 to 50% of those will be randomly selected. There will be 1 segment randomly chosen per selected primary sampling unit, and that segment will be around 50 households. All the households within the selected segment will be visited, and all school-aged children residing in the households will be included in the survey. As you can see, the reason it's called the oversampling is due to the proportion of primary sampling units that we will be surveying. The primary outcome is prevalence and intensity of infection based on duplicate keto-CATs, thick smear, and single urine filtration and urine dipstick readings on a single-day stool and urine samples. The secondary outcomes are availability and access to water and sanitation facilities at home, socioeconomic status, and behavioural and occupational risk factors, which will be predictors robustly describing the archetypes. The 4 countries selected are Côte d'Ivoire, Ghana, Liberia, and Togo. They were selected by anonymous vote by the SOS Technical Advisory Group, following a presentation and discussion on potential planned national mapping surveys, which could be leveraged to conduct the SOS, the archetypes those countries represented, and based on which archetypes there is existing data that could be used in the phase 3 simulations. The existing data are predominantly in East and Southern Africa, hence why the SOS countries are within West and Central Africa. Ghana are due to start their survey training and survey in a few weeks, and protocol finalisation is underway with the other 3 countries. With the SOS, from the design, implementation and analysis, we expect that there will be a survey design or a small selection of designs which can be presented to the WHO's technical working group for consideration on which are the optimal programmatically feasible survey designs for decision making. And we're excited to keep you updated with the progress as it unfolds. Thank you for listening.
Well, thank you very much, Fiona. It's fascinating to see how this project is developing. Such an important project for the schistosomiasis community, and it's wonderful that so many different groups have actually contributed to this. Good to see you now in phase 2. We look forward to phase 3, and good luck. Very much good luck with the project. Before we move on to our country experiences, I wonder if I could ask MYT to share the results of the first 3 questions from the poll. Okay, that's interesting. 43% of people working in research, program intervention 33%, and primarily work on M&E 15%. Interested to see what the others are up to. Okay, so now it's, oh, sorry, must move on to poll 2. Everybody seems to, well, 75%, 74% understand precision mapping. Some are a little bit unclear, so hopefully we will begin, you'll know a lot more by the end of the session. Next poll, please. And poll 3, mapping surveys, a lot of experience with mapping surveys, 62% as opposed to 38% who haven't that experience as yet. Thank you very much. There'll be some more questions coming up in the poll later on in the meeting. It's now my pleasure to pass on the chair of the next session and the discussion that follows to Cosmos Nguyen, who is the Global Technical Lead for Schistosomiasis and SDH at Sightsavers. Thank you very much, Cosmos, for doing this job, and over to you.
Thanks, David. And hello, everyone. Please post your questions in the chat on your screens. We'll now hear from different countries how precision mapping was applied in 4 different settings. Our first speaker is Dr. Wycliffe Omondi, Head of Division, Vector-Borne and Neglected Tropical Diseases, Kenyan Ministry of Health. He'll inform us about Kenya's experience on precision mapping.
My name is Wycliffe Omondi from the Ministry of Health Neglected Tropical Diseases Program. Allow me to share with you the Kenyan experience in putting precision mapping of schistosomiasis into practice in the country. Kenya has relied on a multiple of data sources to reconstruct its endemicity map for schistosomiasis. These data sources include research institution and academic institution, with few generated from program activities. Endemicity has been observed majorly in the western part of the country, the central part of the country, the coastal region of the country, with few pockets of transmission in the eastern, northeastern, and northern parts of the country. Using this available data, the National School-Based Deworming Program initiated mass treatment of schistosomiasis in selected schools. As you can observe from the maps, you will realize that a number of implementation units have never been surveyed and have got no information on schistosomiasis, while those that have been also surveyed do not meet the minimum threshold of at least 5 schools per IU. In order to concentrate in providing intervention for schistosomiasis, the NTD program launched the breaking transmission strategy with intent to increase mass drug administration coverage to areas that require treatment. In bid to do this and overcome the challenge of not knowing where there is ongoing transmission of schistosomiasis, the program partnered together with Ascend to conduct granular mapping in the coastal region of the country. The coastal region consists of 6 counties, 26 sub-counties or implementation units, and 130 wards, which are equivalent to sub-districts. The mapping followed WHO sub-district mapping guideline and was intended to be conducted in schools. However, due to school closure as a result of ongoing COVID-19 transmission, the program switched from school platform to community platform, in which villages serving the initially selected schools were utilized to obtain the school-aged children aged between 8 years to 14 in each of the selected school catchment area. A sample size of 50 was obtained, and then total sample size was 32,500. In addition to stool and urine sample collected, water sanitation and hygiene questionnaire was also administered. The results from the 130 wards surveyed was amazing. And from the PowerPoint in projection, out of 130 sub-districts, only 72 required treatment. Finer details can be obtained in the slides. What I need to underscore is that only 72 required treatment. In further refining the results obtained, I would like to indicate that the information obtained refined schistosomiasis distribution within the coastal region and provided us with additional insights which we never had before the mapping exercise. Additionally, the results provided clear and accurate data on the number of people who require treatment, and this number increased from the 196,000 school-aged children that were initially targeted in 13 IUs to 2.1. And the data that was obtained from the mapping exercise enhanced planning for the mass drug administration, which was conducted afterwards between March and April 2021. A number of lessons were learned. One, that there was a varied transmission of schistosomiasis even within each IU, and that this WHO sub-district mapping protocol for schisto can be adopted at a much lower level in various countries, and that it is possible to treat a section of the IU only targeting those eligible sub-districts, and that the mapping protocol is feasible within the ongoing COVID-19 transmission. In conclusion, I would like to highlight that precision mapping provided evidence of treatment needs at sub-district level, and that this information enabled the Ministry of Health to shift from school-based platform to community-based platform. And from the results, the prudent use of the resources has enabled us to shift from just control to elimination of schistosomiasis in sections in parts of the country, such as the coastal region. This mapping would have not been possible without the contribution of the institutions and persons highlighted in this slide. Thank you.
Great. Thank you, Dr. Wycliffe. The second speaker is Dr. Humphrey Mazigo, Senior Lecturer and Associate Professor at the Calicut University of Health and Allied Sciences. He'll be sharing Tanzania's experience of precision mapping.
Good morning, everyone. Good afternoon to the rest of the world. My name is Humphrey Mazigo. I will be presenting about precision mapping of schistosomiasis and the soil transmitted helminths in 6 regions of northwestern Tanzania. Tanzania is known to be endemic for schistosomiasis and the soil transmitted helminths, and the available data indicate that 52% of the Tanzanian population is estimated to be infected with schistosomiasis, and the country is second after Nigeria for having the highest number of cases. And the disease is caused by Schistosoma mansoni and Schistosoma hematobia. The country is also endemic for soil transmitted helminths, all species, and the northwestern region around the Lake Victoria is a region which is known to be highly endemic for schistosomiasis and the soil transmitted helminths. The two maps shows the distribution of soil transmitted helminths and the schistosomiasis mansoni around the Lake Victoria zone. So precision mapping of schistosomiasis and the soil transmitted helminths in Tanzania, especially on the northwestern region, was done in 2004 and 2005, and the mapping included 86 schools located in Shinyanga, Tabora, Mara, Kagera, and the Mwanza region, and as a result showed that the area was prevalent to Schistosoma hematobia and the Schistosoma mansoni, with mansoni restricted along the shoreline of the Lake Victoria, and the hematobium distributed more south to the Lake Victoria. Hookworm was widely distributed in the dry areas, and the Ascaris lumbricoides and the Tracheus tricula was prevalent in the western region. The mapping served as the basis for mass preventive chemotherapy, which has been going on in the region for the past 15 years. So why do we need to map now? The question we have here is, what is the current status of schistosomiasis and the soil transmitted helminths after 15 years of repeated rounds of treatment? And why mapping then? We need to understand the current situation before MDA, and we also need to obtain information which will help in making decisions and see which areas will benefit from the MDA and prevent wastage of resources. And the map on my left side shows regions which were involved in the mapping exercise, and the map on my right side shows the distribution of schools in various ecological zones, with schools denoted by the black dots are schools which were far away from any water bodies, and the green one were within 1 to 5 kilometers, and the red one were within the radius of 1 kilometer from less than 1 kilometer from the water bodies. And this work was done by the Catholic University of West Sciences, which is located in Mwanza along the shores of the Lake Victoria, and it included 6 regions, 29 districts, more than 17,000 school-aged children, and the schools were selected based on the ecological location. So in terms of methodologies, the map on my left side shows a distribution of schools which were involved in precision mapping, and the schools which were involved in sentinel site assessment in green color. So the study involved more than 17,000 school children, We selected 60 children per school, 30 boys, 30 girls, and a total of 290 schools were involved, 50% for precision mapping and the other 50% for sentinel site assessment. We collected a single urine sample and a stool sample and processed them using the urine filtration technique and the cattle cars technique. The team had 40 laboratory technicians, 10 research assistants, and 10 drivers. So in terms of results, overall we had moderate prevalence in all the regions for schistosomiasis and the soil transmitted helminths. High prevalence of Manson in Kigoma and Mara and Mwanza. High prevalence of hematobium in Simiyu and Shinyanga, with hookworm being widely distributed, especially in the dry areas of the study sites. And in terms of intensity, majority of the intensity were of light to moderate, with heavy intensity of infection observed for Mansoni and hematobium. And also we tried to see how the intensity are distributed in regions, and most of the area had moderate right to moderate infection intensities. And here is a map of the Mara region showing the distribution of schistosomiasis and the soil transmitted helminths. It's an example of the many maps we have developed from the data. So what can we learn now from this data? What is the conclusion we can draw from the current mapping and the sentinel site assessment exercises? So schistosomiasis and the soil transmitted helminths infections are widely distributed in the 6 regions of the northwestern Tanzania, and the majority of the infections we observed are of light to moderate intensities, and the heavy infections is only seen for Schistosoma mansoni, Schistosoma hematobium. Schistosomiasis and the soil transmitted helminths precision mapping results are important for planning the next rounds of MDA and monitoring the impact of MDA on prevalence and intensity of infections. In terms of planning for the MDA, surely not all districts need supply of albendazole to every child, and not all districts need every year annual round of MDA. So there is a need to change treatment strategies from blanket mass treatment to every district to a more focused treatment at the ward or at the school levels. And also it is time to consider inclusion of the adult population for treatment against schistosomiasis and the soil transmitted helminths, because this is a kind of population which keeps maintaining the transmission of the two infection. Thank you for listening.
Thanks very much. Please don't forget to post your questions in the chat. Our third presenter is Professor Louis Albert Chwemchwente from the University of Yaoundé 1, who will cover Cameroon's experience on precision mapping.
Dear participants, it is a pleasure for me to share the experience and the way forward for precision mapping of schistosomiasis in Cameroon. Let us start by reminding the rationale for precision mapping. In general, the mapping aims to guide the selection of area eligible for control intervention and to allow, after several years of intervention, the monitoring and evaluation of the impact of the control program. Therefore, it is crucial to ensure the high quality of mapping data. In Cameroon, we compare the data from conventional and precision mapping, and we conclude in a paper published in PLOS NTD in 2018 that precision mapping is the innovative tool and the way forward to shrink the map to better target intervention and to accelerate our progress towards the elimination of schistosomiasis. From the key evidence of the need to conduct precision mapping, I will highlight two in the present presentation. First, the lack of data for the majority of sub-districts and the complexity of interpreting the available mapping results. For example, for the following 6 health districts, in 2010, mapping was conducted in very few schools and sub-districts. In 2018, we significantly increased the number of schools and we cover all sub-districts by including at least 1 school per sub-district. The compare results clearly show the impossibility to extrapolate the sub-district endemicity where there are very few or no data at all. For example, based on 2010 mapping data, the health district 1 was considered as non-endemic, whereas several sub-districts with the highest endemicity were not captured in health district 2, 5, and 6, as demonstrated by 2018 mapping. This example clearly shows the misclassification of several health districts due to a lack of data at sub-district level. The second evidence for precision mapping is the difficulty to monitor and to evaluate the impact of control intervention in those sub-districts without previous update data. The example of these 2 health districts clearly illustrate these difficulties. In Health District 1, the 2018 precision mapping show that the intervention should be mainly focused in 1 over the 18 sub-districts, while surveillance should be maintained in others. For Health District 2, precision mapping revealed very high transmission settings that were not detected before, like illustrated here. From our different experience, we conclude that precision mapping allows a better understanding of schistosomiasis distribution in order to optimize our control intervention. The following 2 examples clearly illustrate this. In the first example, precision mapping showed that the transmission of schistosomiasis was mainly focalized in very few sub-districts. It is not necessary to conduct mass drug administration in the entire health district as it was done before. This led to a rational use of drugs. In the second example, precision mapping show the occurrence of schistosomiasis hotspots in 1 of the 6 sub-districts. We focalize transmission sites in other sub-districts, very few. This also allows a rational use of drug in this health district. In conclusion, we define precision mapping as conducting sampling at a much finer geographical resolution, potentially examining all schools within every subunit in each implementation unit in order to eliminate the error caused by missing the focal variation in schistosomiasis prevalence. Regarding the way forwards, the map of the different survey conducted in Cameroon in 85, 2010, and 2018 illustrate the mapping gap at sub-district level and raise the huge challenge to complete the precision mapping all over the country. All this gray area in this map clearly illustrate the mapping gaps at sub-district level. I would like to thank all partners who support the control effort in Cameroon. Thank you for your attention.
Thanks, Professor Louis Albert. We will now hear from Jean Bosco Bonigaba, Acting Director of Entities and Other Parasitic Diseases Unit at the Rwanda Biomedical Center. He will share Rwanda's experience of precision mapping.
Thank you for the opportunity. Precision mapping. Rwanda has been implementing different approach for precision mapping based on school-based approach. But recently in 2020, we moved from school-based approaches to community-based approach where we used villages. In the sampling, we have a different shift. First of all, as we moved from school to villages, we selected villages as the sampling unit. The second shift was about the selection of communities, where we include also adults. Also, the third shift was about selecting people who were to be surveyed during our mapping, where we used all people, where we include all people in each household, representing each age category. Here, age categories were defined in 3 categories: 1 to 4, 5 to 15 years, and 16 years and above. The second shift about selecting the high-risk communities, GIS was the tool that we used to map all villages and all water bodies in the country. After mapping all those areas, by intersecting admin structures with wetland ecosystem, we extracted the villages that were adjacent to water bodies. After having all those villages, we went further to cross-check using different technologies, and we saw that some small, isolated, and inside the protected areas, marshland or wetland were removed. Then we remain with around 6,000 villages. Now, the second step, after having all this information of villages that were really at risk of schistosomiasis, we went far to collect information on each village so that we have information about risk factors, I mean activities that are being implemented in those type of water bodies, but also having number of people at risk or type of ecology, which kind of wetland surrounding this village. Now, the next step was, after having this information, we tried to see what are now the villages that are really at risk. We saw that some villages were hills, were having hills, were having forests, were having geographies that do not favor the transmission of schistosomiasis. So to the villages, even if they were surrounded by water bodies, but they did not present a risk for schistosomiasis because they were forests, they were hills, without any people using this type of water body. Then we moved those villages. More than 51% were such villages that were not eligible for risk of schistosomiasis. Then we remain with 3,000 villages. Try to rank the risk level of each village using ecological and epidemiological factors: type of water body, type of human activity, number of people using that type of water body, the proximity of household to that water body, and also if this village was located into previous endemic area. Then we found that villages were ranked from 1 to 9. And the selection of the village to survey was based on the risk level. The high ranked risk village was the first to be selected, but also looking at geographical representation of villages in a district, but also seeing the ecological representation. All types of water bodies were also to be represented as it can be seen on the map. Those selected were put into green color. After having the final list of villages ranked, then we selected the villages. After selecting them, we selected 10 villages per district. We went further to list the number of households in each village, but also to select 20 households per village. And in each household, we were also to select one individual per age group. Age group that we include in our survey, it is 1 to 4, 5 to 15, and 15 and above. And each household were to give one individual per each age group. Individual from the first household was selected randomly, but the second household selection was based on the gender of the previous household, so that we can see the representativeness of gender, and so on for other following household. For household that did not have all three age groups, we selected the available age groups. Then the missing age groups were selected in household that had all age groups. What were the results? Among villages that had more than 10% prevalence of schisto, 15% of villages were very new, not previously known for schistosomiasis. Other findings: prevalence of schisto using CCA was very high in preschool age children compared to other age group, because in school age children it was 35%. What are the lessons learned from this methodology, community-based precision mapping? It is that the community-based mapping is very practical, effective when diligently planned and coordinated. There's no huge funding necessary because we had this local government and the local health facilities involvement. Also, we learned that history and ecologies alone does not determine a village at risk, because we saw that activities that are implemented in that water body is very, very crucial to determine if the village is at risk, because more than 50% of villages that were close to water bodies were not having risk factors, or not eligible for risk of schistosomiasis transmission. The last one, we saw that schisto in preschool age children using CCA should further be explored, because we saw high positivity in this specific age group. Thank you.
Many thanks to the presenters for doing a wonderful job in demonstrating the application of precision mapping. I'll now ask all our speakers, Pauline, Fiona, Wycliffe, Humphrey, Luebe, and Jean Bosco, to turn on their cameras for panel discussion and Q&A. Thank you. We have a couple of questions here and comments. The first question goes to Dr. Pauline Munzi, and it reads: how can countries use sub-district analysis tool and environmental suitability maps to prioritize areas needing precision mapping? Over to you, Pauline.
Thank you very much indeed for that question. I did touch on it a little bit, and I am glad to just stress again that this is indeed a tool that can be used when planning your mapping protocol. It is not a mapping tool itself, as a number of people had thought earlier, but you can use it to identify areas that do not have data, and therefore be able to prioritize in your sampling. The decision tree in this tool does take you through the quality of the data, such that whatever data is available at the community level is then given a quality grade, so that you know what areas to prioritize, even if they add data already, depending on how that data was sampled, what was the method used, or if there was no data at all and transmission is suspected. So we think that it is indeed a very helpful tool. It's a very first step in knowing what is the gap, and then on to the sampling stage and protocol development. Thank you. Over to you.
Thanks very much, Pauline. The next question goes to Dr. Fiona Fleming. How will this oversampling study help inform the cost effectiveness of mapping and impact assessment protocols?
Thanks, Cosmas. So just to elaborate a bit more than what I said on the presentations, in phase 3, we'll use the data collected from the schisto oversampling surveys, plus any existing data sets where precise sampling has been conducted across different archetypes. These data will then be incorporated within a model-based geostatistical framework with other risk predictors and used to generate a prevalence surface of schistosomiasis by Schistosoma mansoni and hematobium, so by the different species. Then from this prevalence surface, and due to the sort of detailed nature of the data collected during the surveys, it will represent the true prevalence across different or multiple archetypes, and we'll be able to test the performance of many survey designs. So ultimately, we'll be able to look at the 3 different survey designs which were developed by the WHO Technical Working Group, which were the lot quality assurance sampling, proposive sampling, 2-stage cluster sampling, and we'll be able to compare those and other survey designs, perhaps including some of those, the precise sampling methods that we've heard about in the presentations by colleagues just now. And we'll be able to compare them in terms of how much it cost to conduct, what sample size was required. Obviously, the smallest sample size that gives the maximum amount of information would be the preference, what data are required to determine the sampling frame, and the expertise required to conduct them. So we'll look at those factors and then be able to determine which is the most cost-effective and programmatically feasible survey design for health ministries to use.
Thanks, Fiona. The next question is addressed to Wycliffe, Omondi, and Jean Bosco. Has precision mapping findings led to new opportunities for drug allocations or distribution? So maybe Wycliffe will go first, and then Jean Bosco after.
Thank you so much, Cosmas. I want to agree that after conducting the precision mapping in the country, of course, with the refined map, definitely we found new areas where we needed to allocate the medicines or praziquantel, where initially we were not targeting. So definitely, of course, new areas were identified. And as I think, if you go through the charts, we also expanded from just school-aged children to adults. So definitely, we expanded our scope in terms of administration of praziquantel. Over to you.
Thanks, Wycliffe. And Jean Bosco.
Thank you. This precision mapping helped us to know the areas that were undertreated, because in our setting, we saw that the population and the areas that we treated doubled after this precision mapping, because before we targeted around 1.1 million, but for today, after the precision mapping, we are targeting 3 million, which means it doubled, almost more doubled than so, which means the precision mapping helps us to know all areas that are endemic and also to orient efficiently our drugs so that they're taking the real people that are at risk of schistosomiasis. The second point is that having adults also in the mapping helped us to see the burden that adults are bearing so that we can now mobilize resources for those people because they are now the source of infection for children that are dorm. So having the data for adults, even for preschool age children, help us to really have the full picture of how schistosomiasis is in the country so that we can mobilize resources to eliminate schistosomiasis in Rwanda. Thank you.
Thanks, Jean Bosco. Our next question is addressed to Professor Louis Abe and Dr. Humphrey Mazigo. And it reads, how has precision mapping impacted cost effectiveness of schisto programs? So Professor Louis Abe.
Okay, thanks, Cosmas. So in the presentation, when you compare, for example, the conventional mapping and the precision mapping, we realize that with the precision mapping, in some of the districts, we were able to have more than half the district that were not endemic and not require any treatment. So this precision mapping allowed to focus our energy and resources in those sub-districts that require treatment. So we can save money and drugs with this approach. But we also have in mind that in some area where the previous data do not highlight the sub-district transmission, we might also end up have some sub-districts that will be included in our massive administration. So it is a balance, but in overall, it's very important to have precision mapping at this sub-district level. Thank you.
Thanks very much, Prof. Dr. Humphrey Mazigo.
Yeah, I just want to say that from the data which we have presented on precision mapping and also the other ones which we have not presented, clearly, I do agree with Pauline about the issue of treatment because we don't have data to some of the areas and we keep pushing, putting a lot of pasquantel and albendazole to these areas. And now with the data, that means we are now going to decide what we can say using evidence when we are planning for the next rounds of MDA. There are districts which clearly don't need MDA every year. There are districts which do not need MDA even after 3 or 5 years, but we keep putting drugs every year. So that is a wastage of resources. So to be cost effective, we really need to utilize the data. We need now to focus really to the ward level because I didn't show one of the districts where you can just see the infection is only concentrated in particular wards. And the other wards, the prevalence is below 5%. And then you are just putting the resources for all the districts. So that means that is where the direction we are going now. To be cost effective, we need to have a focused kind of treatment because the infection have gone down. We were thinking about the heavy infection intensities. They have gone down after all rounds of MDA. Now we are talking about the right infections, no infections, and the moderate infection. So it is time now to change our strategies to be more cost effective and then use the remaining drugs which we allocate for our school children now to put them in the adult populations because their population is not treated. Then they maintain the transmission and exactly what we see is a moderate and the right infection intensities. Maybe they are maintained by the adult populations. That's why we keep seeing them in the children, despite that we do a lot of MDA every year. So if we put also treatment in the children, in the adult population, now we can be talking about eliminating schistosomiasis as a public health problem or soil transmitted helminth infection. Thank you.
Thanks very much, Professor Mazigo. Lots of questions. I don't think we'll have to take all of them because of time, but this one is from Ross Stoddard to Pauline. In terms of the 19% of school-age children overtreated versus 18% undertreated, are you also able to say that the real cost of money saved is over and above the important ability to reallocate praziquantel to adults, please? Hi, Pauline.
Yes, please. Yeah, thank you, Professor Stoddard. I thought that was really a very important question. And what I was saying in the chat is that we see sort of a balance between the children that were missing treatment and the number of children that were not receiving treatment. So overall, it doesn't change much. The quantity of medicines that are still needed in the region and the level of donation from the from our pharmaceutical partners hasn't changed either. But the overall benefit is, where we're targeting the population. So we haven't calculated any savings in terms of dollars. I don't think that's going to be significant when we have all of the countries put together. But we are on a country by country basis where the data looks very good, and there are some savings from the sub-district data analysis from the total amounts that that particular country has always been requesting from the donation program, having discussions with those countries to provide medicines for the adults. Because when you conduct the district data analysis, you have a better understanding of where those adults are at lower levels, as opposed to when you had estimated populations at district level. So it's becoming easier. And again, hopefully towards the end of this year, when we have a lot of countries finalizing their 2021 and 2022 applications for 2022, implementations for 2021, we can have this data available. Thank you.
Thanks, Pauline. The next question is from Betty to Fiona, and it reads, can oversampling be integrated in the ongoing surveys in countries other than those four?
Yes, and thanks to Betty for that question. And so the four countries were selected because they represent archetypes within West and Central Africa. And there's, we know that there are other surveys that have been conducted in West and Southern East and Southern Africa, especially for schistosoma mantsoni, where we have quite a good understanding of detailed epidemiological understanding of those archetypes. So that's why the surveys have been focused in West and Central Africa. However, if there was further funding, we're also sort of limited, as we always are in these circumstances, by, although we've had very generous funding from USAID and the Gates Foundation, we are restricted in how many we can conduct the surveys in. And so if there were additional funding that were available, then we could sort of also see what other archetypes we have gaps in information for, then perhaps we move forward with considering other places.
Thanks, Fiona. Unfortunately, we can't take all the questions. I hope some responses were provided in the chat, and if you can write also directly to the panelists. Thanks, everyone, and thanks to our panelists. I'll now hand over to Dr. Anouk Gobras, Director of Communications and Programs at the Global Schistosomiasis Alliance, for the next part of the meeting. Over to you, Anouk.
Thanks very much, Cosmas, and hi everyone. I hope you have enjoyed the talk so far. It has certainly given us a lot of food for thought and for our discussions in the breakout rooms. So to help you get into the mood for some deep diving into the precision mapping aspects of schistosomiasis programs, we have 3 polls that we'd like you to take part in. So the first poll is a simple yes, no, or maybe question. And Nick, if you could just bring that one up. Do you think precision mapping is needed to progress to the WHO roadmap goals for schistosomiasis? So I'm just going to give everyone a chance to input whether the answer is yes, no, or maybe. Please do put in what you think of that just by clicking yes, no, or maybe. I hope everybody can see it. Just realized that I can also put in what I think. And hopefully, Nick, have we given enough time to get the results up from that particular poll?
We've got 77 out of 100.
Well, brilliant. I think we can probably show that the results of that particular poll. Ah, brilliant. I see there are some people who are putting maybe, but most people have put yes. The maybes are quite interesting as well, because I suppose that means that there are some things they want to think about, and it depends how precision mapping is implemented. We're going to put the next poll up. So Nick, could you share the next poll, which is a multiple choice question? What do you think are the key benefits of precision mapping for schistosomiasis? So please, I'll give a bit of time for everyone to indicate what they think. You can click more than click on more than one answer there. So please do that. And this is a bit of a warm-up exercise to get us thinking before we move on into the breakout discussions. So some of these aspects will be touched on in the different breakout rooms. And this is to get you thinking a little bit about that. Nick, how are we doing with the responses so far?
We're 61 out of 97.
That's not bad. I think we could probably show the results of that as well. Ooh, nice. Lots of different responses there. So it seems to be that the improved targeting of interventions is the most key benefit of precision mapping. So that's great to see that. And now we'll do our final multiple choice poll. So Nick, could you bring up the next one? What do you think are the key challenges for precision mapping for schistosomiasis? And again, you can click on more than one answer. I think, I'm already getting lots of stuff in, which is great. I'm sure there are a lot of thoughts about this. Looking forward to capturing the feedback on this particular question in the breakout rooms. We do need to consider what are the challenges and what questions do we need to answer in order to support precision mapping activities for schistosomiasis. So fantastic. And yeah, Nick, I see you're showing the results, I think, already, aren't you? Or is that just me that can see that?
That's just you.
Right. It's brilliant. I can see all these things jumping around. Please show it for everybody, I think. Yeah. Wonderful. I did enjoy that. And that's great to see. So the increased cost of mapping implementation is quite a challenge, and the need for better diagnostics for schistosomiasis precision mapping is another key challenge that has come out of that. So I think that's really given us some already some things to talk about and think about in our next in the next part of our meeting. So you know, we will be now splitting into 3 breakout rooms to discuss and capture your thoughts on some of these aspects of precision mapping. When you registered for this meeting, you will have chosen your preferred breakout room, and the brilliant MIT events team will be putting you into those breakout rooms shortly. But each breakout room has a facilitator who will lead and support discussions, and we will be using an online easy retro board to capture your thoughts and comments on these aspects of precision mapping. I'd like to introduce you to the facilitators of the breakout rooms, as you can see on your screen. So we're going to start with Cosmas, who you've already seen, who will be chairing the Q&A, who has chaired the Q&A and will facilitate breakout room 1 on what is the additional value of precision mapping in helping NTD program managers decide on schisto intervention strategies. And then we also have Dr. Stella Keffer, who is the technical advisor at Oriel Global Health and Kemri, and will facilitate breakout room 2 on best strategies for precision mapping implementation and approaches for site selection. So that's room 2. And then we have Dr. Susie Campbell, Senior Monitoring, Evaluation and Research Advisor at SCI Foundation, who will facilitate breakout room 3 on merits and demerits of community-based survey versus school-based surveys. We will have 15 minutes for this breakout room discussion, so 15, which I am sure will go by quite quickly. Just to add also to our Francophone colleagues, there will be someone who can assist with French translations and French speakers in each breakout room. So please do feel free to input and the Easy Retro boards will have the questions in French as well as in English. So please do feel free to put in your thoughts in French if that is your preference. Okay, I think we'll make a start. So welcome everybody, welcome back. I hope you enjoyed the breakout rooms and you have shared your feedback and thoughts on precision mapping. As we continue to move towards the WHO roadmap goals for schistosomiasis, we do need, we need these important opportunities to come together to leverage each other's learnings of tools and methodologies, what worked, what are the challenges, and then discuss how we can address them, whether that is by adapting existing tools or designing and testing new ones. So I hope you did have lots of input into those Easy Retro boards. I would like now to invite the facilitators from the breakout rooms to share with us some of the comments and discussion points from their breakout rooms. Perhaps we can start with Cosmos. If you could maybe briefly, just 2 minutes, remind us what the topic of your breakout room is and tell us some of the highlights that were shown.
Thanks, Anouk. We're looking at the value of precision mapping on decision making, and it came out clearly that focal treatment decisions are required rather than blanket treatment because data now suggests that areas being treated, some areas are being overtreated while others were undertreated. So that focalized information really helps programs to better target areas of need. We also, from the group, mentioned that prevalence, intensity, and wash information, these 3 are very critical in decision making because prevalence definitely helps to identify what treatment regimen is required, while intensity would tell us if at all we are getting close to the roadmap goal, the WHO elimination roadmap goal. And wash data helps to put in place environmental determinants of transmission. And we saw that precision mapping in the long term, in the short term may be costly, but in the long term may also help with cost savings because treatment program implementation is likely to reduce in terms of cost because you'll be able to know exactly where treatment is required. And lastly, we also talked about the use of GIS information in mapping that would really be useful in decision making. Thank you.
Thanks very much, Cosmos. That sounds great. And now, Stella, please could you remind us the theme of your breakout session and maybe highlight some discussion points that were raised during your breakout room?
Thank you. The theme of our room was to understand better strategies for precision mapping and implementation and approaches for site selection. So we had 4 questions and lots of views on that. So one is how should we select sites? And what came out is, spatial consideration, nearness to water bodies, historical data, and years of MDA over implementation units. And who should be sampled? A good majority still think school-age children should be sampled based on evidence that they are the best proxy to endemicity, but there are people also who think that the population at risk, so entire population, and also people who have occupational risk. So in terms of sites, how many sites? This had varied thoughts, and most think resources, risk and distance to water bodies. And lastly, what diagnostic tools should we use? So CCA, some say CCA, some say urine filtration, and others say, depending on the endemicity, that will determine which diagnostic tool we use. Thank you.
Thanks very much, Stella. That's great. And finally, Susie, please do remind us of the title of your breakout room and highlight some interesting points that were shared. I was in this one, so I know how much feedback we got.
You're on mute, Susie, if you just want to pop on your microphone. Thank you.
My apologies. Yes, thank you very much, Anouk, and thank you everyone for participating in this. This was a breakout looking at the advantages and disadvantages of community-based versus school-based surveys for the mapping. And as you can see, if you can see the screen, there was a lot of comment added under each of the 5 questions that we had. For the advantages of community-based surveys, the main ones that were coming through in quite significant numbers were the ability to understand transmission and morbidity potential across the broader community than school-aged children. And also further down, the opportunity to target interventions, therefore, to people most at need. And someone raised a very important point that children who are out of school may in fact have high morbidity from schistosomiasis because of missed potentially previous mass drug administration rounds. And so that's an important group to be able to capture in community-based surveying. In terms of advantages for school-based surveying, a very large quantity of the answers here related to the ease of reaching the required number of participants and the ability to do that field work. It was also a very important point raised that is comparable with historical data, that those trends over time. In terms of the challenges of community-based surveys, first of all, there were a number of responses here around the logistics, the sampling frame, the collection of stools in household, the difficulties with diagnostics, higher cost for implementing community-based surveys, and also the ability to reach people who are on the peripheries of their communities. For challenges of school-based surveys, over and over again, the point that was raised was around school enrollment and attendance, wherein it's low, is very challenging to, or missing the non-enrolled school-aged children. And the representativeness of data, the ability of the health and the education sectors to link, and the selection bias issues. And then in terms of whether or not a hybrid model might be feasible, people generally felt that yes, it could be, and a number of the answers seem to be about using children as a staging point to then go and reach their families, or to reach as other staging posts within the communities as a logistic approach, but the technical aspects of the whys and wherefores with that would need to be carefully considered. And then just the very last point that I will raise here is that the gender issue with girls not being in school also needs to be carefully considered. So thank you very much.
Thanks very much, Susie. So I think that shows you all the different things that were captured. We are going to use these easy retro boards to write up our report to Core NTD about schistosomiasis precision mapping, as well as the presentations from the countries that we showed were shown earlier. So thank you very much to everyone who participated. I am now going to hand over to David. So David, over to you.
Wow, what a fantastic meeting. so much discussed, so much food for thought. Thank you all very, very much. I'm sure you'll agree that it has been most worthwhile and an interesting session. I think we're going to have to take a little bit of time to assimilate all the points from the breakout sessions. It's amazing what ideas come through in that 15 minutes. We've got some really good thoughts going on there. And as Anouk has mentioned, we'll try and capture that in the report. Now, two things that are very clear, I think. Firstly, great progress has been made by countries already in precision mapping. Slightly different methods and approaches being taken, but nevertheless, great progress has actually been made. And there's no doubt from all the comments received and all the thinking and the evidence that's coming forward, precision mapping is actually going to be central to achieve WHO and country objectives to achieve elimination as a public health problem. And for those that can manage it, to move on towards interruption of transmission. There can be very little doubt about that. And I think the oversampling study is going, and other things going on, are really going to be beneficial in helping us to fine-tune and progress with precision mapping. And secondly, I think the other thing that's came through from all the presentations was really the benefit from sharing experiences, from partnerships and working on new protocols, working on how to actually carry out the logistics on the ground. All these things so important. So I think it's really important. A message again is to let's keep those partnerships going and make sure that we can move forward in the way that we wish. So I would also like to thank all those people who contributed to the successful session. These kind of conversations have been going on for some time. We had the previous Core NTD sessions, but this particular idea came via discussions with Laura Appleby and Stella Keffer from Oriel Global Health in relation to their ongoing work, primarily in East Africa, with discussions with GSA. And I would say that Stella has been a driving force here behind the meeting, aided by Elodie Yard and Jane Lillywhite and Irene Wagner. So thank you very much for them. A big thanks to Debbie and all at MIT. You put on a great program and operated it perfectly. A big thanks to Lee from Core NTD, and indeed to all at Core NTD for promoting this important session and allowing the schistosomiasis community to get together in this way and share thoughts and ideas. So again, huge gratitude to all the speakers for preparing their presentations on time, to all of you out there for sticking with us throughout the meeting and participating, and a special word of thanks to Anouk Guvras from GSA, who skillfully managed the meeting from the beginning of the process to the end. So thanks to everybody there. The only other thing to say is let's keep this conversation going. It is so important to what we're trying to do for control and elimination of schistosomiasis. So let's keep sharing ideas, sharing experiences. Make sure that you are enrolled with GSA, that you check the website, and make sure you look at the report that will finally be issued. So again, thanks everybody. And I think with that, we're coming up to time. So we will leave it there. Thank you very much and goodbye.